Mute all. Sir, okay, TSS sir is joining now. So let me start the session by welcoming all of you to this 197th episode of Thursday Musings. Uh, Very practical, important topic, a revision for most of us. If some residents are there, a good learning experience for them. So a very warm welcome to all of you. Next slide, please. The chairman of this program is Dr. Tufanpati sir. He's from Cuttack and he's so well known, sir. I'll skip your CV and hand over directly to you. Sir, over to you.
Thank you, Dr. Lim. I also want to spoil time. Next, we have got three vibrant moderators for Thursday Musings now. Dr. Lim Siddiqui, Dr. Amrit Patodasi, Office Bearer of IPS, and Dr. Bishal Chabra from Delhi. I welcome three of you.
Thank you.
Next slide, please. I have the honor to introduce Professor Dr. Mohammad Iqbal Afridi. Alim, I am from a mobile phone. Can you read out the biodata of Dr. Chairpersons? Because here it is also coming and going. Alim?
Yes, sir. Yes, sir.
Please
So,
do
Professor Afridi is MBBS, MCPS, FCPS, psychiatry. Many degrees he have, many affiliation to organizations. His professional experience is HEC Distinguished National Professor from Jinnah Sindh Medical University from Karachi, Pakistan. Adjunct Professor of Psychiatry, Baylor College of Medicine, USA, Texas. He is Editor-in-Chief of Journal of Pakistan Psychiatric Society. He is Country Director of Memory First Aid International, UK. Chairman, Prison Reforms Committee, Government of Singh Services. Member of Senate, Bolan University of Medical and Health Sciences, Quetta. Country Collaborator, COHFIT Global Study. Member of Governing Body, Institute of Clinical Psychology, University of Karachi. And A.Q. Khan Institute of Behavioral Sciences, Karachi. International Distinguished Advisor to Busan Global Academy, UK. He's interested in psychiatry, psychosomatic medicine, and addiction medicine. He has a lot of publications. I think these are visible on the list. So, with so much vast amount of experience, it is our pleasure to welcome you, Dr. Afridi Saab.
Thank you very much for this. Thank you for the actual topic. Thank you.
Thank you, sir. Thank you. Next slide, please. Our other chairperson is Dr. Amit S. Muta, Associate Professor, Grant Medical College and Sir J.J. Group, Mumbai. He is pursuing PhD in sexual problems and management in geriatric population from Grant and Grant College and Sir J.J. Group. He is Joint Secretary of Executive Committee of CSEPI 2023 to 25 of India. Vice Chairman, Sapphire Institute of Ethics Committee, Thane since 2014. He is member scientist, St. Elizabeth Hospital and Research Center Institutional Ethics Committee, Mumbai. He is member scientist of S.L. Raheja Hospital and Research Center Institutional Review Board, Mahim, Mumbai since 2017. Associate editor of Asian Journal of Integrated Nephrology and Andrology. Column editor for the Journal of Psychosexual Health. Awarded Fellowship, Council of Sex Education, Parenthood International in 2015. many original articles, guest speaker at conferences, his core interest being andrology, sexual medicine, reproductive endocrinology, and sexology. So welcome, Dr. Amit. Welcome, Afridi sir. The show is over to you now. One of the persons can introduce the speaker, Dr. T.S.S. Rao. Another can say a few words about the topic, and then we go to the main presentation. Over to you, chairpersons.
Thank you very much for this nice introduction, and I'm very thankful to our colleagues in India that they have given me this opportunity to learn on this very important subject. And I'm sure that T.S. Rao is very capable, and I'm very thankful to all the dignitary that they have provided us this opportunity to learn something about a very special topic, which is considered taboo in Pakistan, India, Bangladesh, and the South Asia. Thank you very much.
If Dr. Amit is there, he can read the CV of Dr. T.S.S. Rao. Dr. Amit, have you joined? If not, I introduce Dr. T.S.S. Rao. He is very well known in our circles. He has a different acronym for his TSS, which we'll discuss informally later on. He is Professor Emeritus in Psychiatry, Chief Coordinator of Psychosexual Medicine. He has been with JSS Medical College, Mysore, immediate past General Secretary of Indian Psychiatric Society, Editor of Journal of Psychosexual Health, President-elect of South Asian Societies for Sexual Medicine, affiliated to International Society of Sexual Medicine, formerly President of Indian Association of Geriatric Mental Health, formerly Editor of Indian Journal of Psychiatry for one of the longest serving tenures, co-chair of Psychiatry and Human Sexuality section in WPA. He has 349 research and review papers, 26 book chapters, Marfatia Award, DLN Murthy Rao Oration Award, C.V. Raman Distinguished Scientist and Acharya Award, President, Karnataka Sexual Sciences Academy. With so much vast amount of experience and for all your sir knowledge and help to us, we welcome you and hand over the session to you. T.S.S. Rao sir, over to you. Please unmute.
Dr. Aleem, there is some interruption in your sound. I don't know why.
Yeah. T.S.S. sir, over to you now.
Okay. Okay. Good evening, all.
Can't hear you. Yes.
Can you hear me?
Yeah,
Yes,
no,
sir.
it's fine.
At the outset, let me thank Thursday Musings, Dr. Tufan Pati Saab, Aleem, Amrit, Chabra Saab, and each and everyone associated, and you have been very kind to me all through. In fact, this was decided at the short notice, but all said and done, I am really grateful for the wonderful opportunity what you have provided to me. Afridi Saab and Dr. Mutta, in fact, they have readily agreed, and I am really happy that the people working in this particular field would be chairing the session, and their contribution would be a great help later when questions and other things come up. This particular presentation, though I have written focus on pharmacotherapy, I'll start with a brief introduction related to what we understand by the term ED in particular and sexual dysfunctions in general, maybe about 5 to 10 minutes focused on that. Then I'll move to the specific discussion of what we call understanding ED and its management. A time was there when we used to say that sex is there in the mind. This is, I saw in the WhatsApp yesterday in one of our fellowship group. In fact, people now they have moved to a different level altogether. A type of tea or samosa or any item which can give you orgasm or erection without much difficulty. The idea is actually that ED is a science, not magic, and a proper understanding of this can help a lot of people in managing this particular problem. I was there in one of the recent ad board program of one of the pharma companies. In fact, they were talking about how actually this ED should be managed. And one conclusion reached was, you establish endothelial dysfunction, you give medication, problem would be solved. But when I raised the issue that many of the things won't happen that particular way, there are a lot of things actually we need to look into. Their question was very simple. Where on earth people will have time to look into so many psychosocial or psychotherapeutic and behavioral issues? People have come with the problem and you have to have a medication and it should correct the problem. Reason appears very simple, and I was thinking and looking into type of patients what we handled. And it reminds me one of the study when sildenafil citrate was introduced in the international market. Everybody believed that all men's problems are solved, so also the women's problem. 2 years later, one of the study which came out with about evaluation of around 2,000 plus couples and their satisfaction with their sexual life, hardly anything had changed. This is the conclusion of that particular paper. Now, it brings us to the focus. That means there is actually something actually happening, which in fact, drug alone is not going to correct it. Drugs are mainstay of treatment now, but all said and done, we should also keep it in mind a lot of other factors. That what can be done and all of that. In fact, in earlier presentation on sex therapy and quite a few other presentations by quite a few people, psychotherapy is involved with these type of disorders, people have discussed. There is a lot of research has happened now as far as the male sexual function is concerned. In fact, if we try to look at the whole range of research that has happened, in fact, almost 80 to 90% of the research may be related to male, and it is related to what we basically call ED to a great extent and to a small extent on what we call premature ejaculation and such other problems. That means a lot of effort has gone into. In my presentation, what I will be trying to do is actually quoting a lot of references, data, and all I'm trying to avoid. One thing is to avoid the boredom. Second one is now there are a lot of things that are very clear-cut and well-established. If somebody is interested in references, what we are quoting, in fact, this is one of the clinical practice guidelines, the second edition brought up by Indian Journal of Psychiatry, very clearly delineates a whole range of research papers that have gone into, and more particularly even from our Indian perspective. We actually, in fact, around 30 papers discuss different aspects. And in Asian Journal of Psychiatry, as Dr. Afridi Saab was mentioning, there are actually, in fact, issues wherein, whether you're talking about Pakistan or other Southeast Asian countries, there is such an amount of taboo. I can tell you very recently, I was there in one of the Asian Congress at Abu Dhabi. My presentation on psychiatry and sexuality was not allowed by the government because the word sexual specifically, explicitly was mentioned there. I had a similar experience for one of the sessions at Indonesia. What it means is, still there are a lot of places where people hardly speak about, and from that angle, maybe the India stands in the forefront because a lot of work has happened in this country related to this particular area. Very recently, IPS textbook of sexuality and sexual medicine very clearly delineates how each of these type of things are managed. And somebody is interested, means I just added these things to bring to the focus, because this particular session I can see a lot of faces. My mentor, Dr. Raj Brahmabhat, is there. I'm seeing a lot of postgraduate students. I'm seeing a lot of experts. So this will be something like via media in between, wherein we'll be trying to look at some of the important aspects, how it is. So before I get into ED, as I mentioned in the introduction, in the beginning, we all aware that ED is one of the important problem, and what earlier used to be called as impotence. Now, taking it for granted that it is a little derogatory, ED is almost like coffee, tea. Anybody can understand this particular word. What Tolstoy mentioned, that man survives earthquakes, experiences the horrors of illness and all of the tortures of the soul. But the most tormenting tragedy of all time and will be the tragedy of the bedroom. And this actually brings us, as psychiatrists, where we actually stand. Let me tell you, as we psychiatrists, I have attended quite a few programs conducted by urologists, endocrinologists, gynecologists, and other specialties. Many of the times, what is their focus would be very limited to what we basically call establishing a particular cause, if it is possible. Otherwise, writing some prescriptions and things like that. As I mentioned in the beginning itself, it is much bigger and much more than that. So from psychiatrist's point of view, and if you try to look at even physical illnesses, sexual disorder and physical illnesses, mental illnesses, actually, there is a lot of correlation. Earlier, it was there in psychiatry section, but now in ICD-11, it has been moved as a special area. But all said and done, there is a direct correlation to these things. What are they? In fact, if we try to look at a little more closely, both of them carry the low self-esteem, interpersonal troubles, dissatisfaction with life, and low quality of life. And you talk about depression, anxiety, substance abuse, and many other disorders. In fact, the sex is one of the things which actually props up very significantly. And somehow we actually try to bypass it or overlook it and try to proceed. But when we come to know, the realization is actually when we have to use medications, and medications produce problem. Patient refuses to take medications. Compliance is a problem. The specialty sexual medicine clinic and diabetes in small scale checkup area, both are together. The diabetologist was telling, Rao, after you came near this place, when we started telling sexual problems, people's compliance and everything has improved very significantly. So non-adherence is a major significant problem, both in medicine and in psychiatry. And one of the most important reasons why they don't take medication is related to sexual disorder. And relapse is so frequent and common. And this is the reason why each one of us, as we psychiatrists, unless we take up this as one of the very important field, we are likely to give way to so many other specialists, and that is actually should not happen. Most patients do not present with sexual complaints. This is one of the extremely important this thing. And jokingly, I almost always say, every person we meet on this earth, in fact, these are sexual problem cases. Yesterday, today, tomorrow. That's all actually the difficulty. They could be primary expressed problems. They have come with, take an example, ED. I still remember our sildenafil trial in the beginning when it was introduced in Indian context. The 22 patients who had presented with ED, of which almost half of them were recognized to have diabetes first time. So it could be primary expressed problems, or it could be early clues of organic, mental, and physical disorders. Diabetes, many of these type of metabolic and other related disorders are recognized first time because the individual has presented with ED. It may be a complication of general medical condition. So one of the important messages, in fact, there may be about 10% of the patients who may initiate their own actually something related to the sexual this thing. You ask one question, do you have any sexual concerns to discuss? This number increases by 50%. So for all those young people who are listening to my presentation here, you must remember that almost as a mandatory this thing, you must ask this question. People are worried what will happen, whether it is a private issue, whether somebody has come for this and I am not asking his concerned problem and I'm asking something else. All legal and such other ideas may come to mind. Please remember, they would be more than happy to tell you. Let us come to the erectile dysfunction. One of the definitions, the earliest, in fact, this is what I'm telling is almost 79, inability to obtain or maintain an erection of sufficient firmness to permit coitus to be initiated and completed. And in the same vein, one of the other, almost about 3 to 4 decades ago, male erectile dysfunction is the inability to achieve or maintain an erection sufficient for satisfactory sexual performance. Even very recent books, other consensus statements and all, if you try to look at, no further improvement as far as erectile dysfunction has been concerned, as far as definitions concerned. So we are aware now that there is actually something problem in getting, maintaining, or actually, in fact, the process involved, there is some actually problem there. One of the very earlier concept was first established whether it is psychogenic, organic. Of course, organic means something secondary to or to physical, more common among the older individuals than young. Young means, in fact, PE as one of the most common likely possibility. Primary or situational. Primary means present from the first attempt at intercourse, or it may be secondary, in which person develops ED after a period of normal function. Situational, wherein a man is able to have coitus in certain circumstances, but not in others. There is another new term, actually partial, they use, wherein actually the individual gets erection, but is unable to sustain it for sufficient length of time, and before he ejaculates, he loses erection. This is actually the concept. But all said and done, there are a lot of terminologies which actually go with that. In the next slide, I'll try to describe in a very brief way. One important message at this particular juncture, what I can give is, if a man is able to perform with one partner, he is unable to perform with another partner, it is primarily a relationship problem rather than sexual problem. We definitely need to look into what all the issues that are actually going on between these two couples. So when we are trying to talk about situational ED, it occurs in certain situations. Factors could be performance anxiety and depression, potential feelings of dread around the sexual situations. Symptoms can be erratic and change depending on the circumstances. Temporary ED, in fact, one of the word actually, the punchline there is actually this, it is not sporadic. Typically tends to be ongoing rather than sporadic. Causes include lifestyle factors that can be modified. So each and every one of us in practice, we are likely to come across many cases with many of these type of issues. One should almost always be remembering and try to actually deal with it. Very briefly, I'll try to just touch upon causes of ED because the management depends on this particular factor. When we say causes, one very important point, what I mentioned just about previous slide was whether it is psychogenic, organic. And when we are trying to talk about psychogenic, I'll not elaborate on this. The point here is there is anxiety, which is actually the primary major common problem. There's a performance anxiety, some psychological trauma, history of sexual abuse, relationship problem, problems with intimacy and other related issues. It could be secondary to depression or so many other related disorders, and guilt and such other related things. In fact, these are all grouped under that. But our job is actually has to be little more, which I'll come 1 minute later. So in clinical practice guidelines, this is one of the table taken from there. It talks about when you are trying to talk about psychological factors, there are a few things which are called as predisposing factors. Many of the times, in fact, very well brought up and extraordinary boy, and many of those points, what actually people talk about, extremely important points. Say restrictive upbringing, actually one of the major common problem which actually has been discussed. Disturbed family relations, traumatic early sexual experiences, inadequate sexual information, insecurity in the psychosexual role. Precipitating factors and maintaining factors, there could be many, and one has to be actually well aware of. These are all available in great detail in our that clinical practice guidelines, what I was just mentioning. When we are trying to talk about our sexual cases management, many of the times in many seminars, I have found people just saying that Freud, it is one of the old story. One need not have to worry at all. But in the sex therapy seminar, I was just mentioning about that particular concept of psychodynamic factors they are extremely important. Consciously, what we see on the surface is something totally different from what we actually don't see. That is what actually the juicy matter is. And conflicts and unconscious material, that could be one actually which is interfering with the treatment. Why this drug acts efficiently responds in individual to another, it doesn't actually happen that particular way, is attributed to this particular fact that there could be many factors other than this, which actually one has to keep it in mind. So one of the message for all psychiatry postgraduates who may be here in this particular program, that don't forget Freud. These are the issues one should almost always be keeping it in mind where necessary. There are a few things very classically established and we are all welcome. Vasculogenic or arterial or cavernous, or including even venous related aspects also possible. Atherosclerosis, hypertension, trauma, diabetes mellitus, chronic renal failure, other systemic disorders. In fact, the list runs in a very significant way. Cardiac issues, and later, in fact, if somebody raises the question, definitely I'll tell you what cardiologists mentioned. See, one of the greatest fear many people actually they have expressed in my encounter with quite a few physicians and others is, in fact, if you give maybe something like a PDE5 inhibitor, the person may die. Whole lot of such these things. Absolutely, it is not true. Only certain length of time for specific type of what we call the problem, there could be, and only very specific contraindication is actually this nitrates and nitrate donors concurrently being present. And even there also, there are a lot of developments have happened how actually this particular problem can be done. Somebody has developed myocardial infarction and you tell him not to have sex. In fact, I still remember one of the cardiologists telling, you can have sex with your wife, not with your girlfriend. The idea here is actually that with a girlfriend, the sex would be very exciting and can lead to difficulty. He is more than willing to die, not because of the heart attack, but because he cannot perform sex. So we have to be a little careful about what we are advising. And one of the important point, what actually people have documented is actually the ED may be one of the earliest stigmata, which indicates the later appearance of what we call as coronary artery disease and related problems. At the end of 2 years, at the end of 5 years, at the end of, in fact, 10 years, in fact, the data is available, how actually it actually works out. In fact, this small diagram very clearly documents the issue involved. And much more important point is actually that it is actually the endothelial dysfunction that is actually important matter. And when you are trying to talk about hypertension, diabetes, and such other things, including hypercholesterolemia and other related things, they function together and they actually produce a whole range of problems. One of the most important common factors, say for example, diabetes, hypertension, dyslipidemia, and add to this actually the nicotine, the impaired endothelium and whole lot of issues that actually crop up secondary to this particular factor. And as far as coronary artery disease is concerned, people have documented ED, and at the end of 5 years, there is almost 80% chances that there could be some problem. Shared psychophysiological mechanisms, pathophysiological mechanisms in ED and CVD has been depicted on the left side. One is aging itself, the range of stress-related oxidative stresses, hypercoagulation, low-grade inflammation, low plasma testosterone levels, prothrombotic activation, and we are all aware how actually this can lead to. In fact, range of biomarkers which indicate and a proper evaluation, in fact, that is definitely called for. This is one more diagram just to bring to the focus. There is both interconnected, both direct and indirect effect, which actually leads to a lot of complications, and ED and coronary artery disease have to be actually looked as one single entity. There are a range of neurogenic causes people have documented. Spinal cord injury, surgeries, diabetic neuropathy, pelvic injuries, and later, in fact, stroke and Alzheimer's and such other related things. In fact, people have documented they could be one of the major common source of actually called the cause for erectile dysfunction. Hormonal is extremely important. One important point to be kept in mind is actually the secondary hypogonadism, which has come along what we call as the metabolic syndromes. specific hormone binding globulins increase drastically, both in case of hypertension, diabetes mellitus, and other systemic disorders. And range of disorders where hyperprolactinemia comes, when specifically we are trying to treat people with certain drugs, particularly for psychiatrists. This particular word is actually so commonly used when you are talking about antipsychotics and things like that. What it actually means is antihypertensives, antidepressants, antipsychotics, all of them actually, in fact, could be actually common cause for creating problems. Anti-androgens, alcohol, cigarette smoking. In fact, this particular diagram may look a little funny, but all said and done, all weaknesses of a man in one picture talks about many of these things men usually in fact addicted to, which can create quite a bit of difficulty. Cigarette smoking is one of the extremely common problem. In fact, not exercising is considered as almost equal to actually what you call cigarette smoking. Loneliness and such other related things are also, in fact, can come under this particular area, which talks about creation of little difficulty in individual. So ED could be because of the so many reasons. And when you are specifically talking about antihypertensives and antipsychotics, one or two small points here only I'll just mention, because maybe there may be one more seminar necessary for talking about premature ejaculation, where we use plenty of antidepressants and small extent antipsychotics, how this particular problem can be handled. All the drugs, any drug for that matter, can create sexual problems. Very specifically, people have documented some of these drugs more likely to affect sexual function. When you are trying to talk about hypertension, let me tell you, in fact, the calcium channel blockers, ACE inhibitors, and ARB inhibitors, to a great extent, they produce less problem. Better to choose this particular group of medications. And there is only one drug, nebivolol, the beta blocker, which has not been documented to have sexual problem. But its efficiency in severe hypertension and all that, in fact, may be questionable, but all said and done, this is actually one of the data available from literature. We have to keep it in mind, any individual 40s, diabetes and vascular problems, they dominate the whole picture. And proper evaluation when you are trying to talk about keeping this particular point in mind is extremely important. So coming back to, in fact, what is the etiology then? This division into something psychological and something organic no more holds good. Now it is almost for all practical purposes taken that it is actually a biopsychosocial model. There are about a small number of people who could be psychogenic, a small number of people were purely what we basically call organic. But in vast majority, it is a combination of these two things what we need to keep it in mind. Let me just go into one case sometime back what I had seen. He was a very learned person and a religious person and a pujari in one of the temples. When he developed diabetes, he had read so much about diabetes. Very next month, he came and presented with sexual problems. What it indicates is he could be having diabetes, but psychological factors, that anxiety, that I may develop a sexual problem, is one of the extremely common problems. And that means there is a biopsychosocial concept. There is one dictum, people use it, and this is only to just make us as a little guideline. What it means is somebody is having moderate diabetes, somebody is having moderate hypertension. At the end of fifth year, 50% of them develop sexual difficulties. There are actually very specific figures are available, but this is one of the important message to convey that this is actually one has to keep it in mind. How common erectile dysfunction in the society? We don't have much data. Prevalence of sexual problems. This is almost like this particular picture. Unless you look at it very closely, chances that you will miss it out. And one of the important concurrence of many researchers is that about 1/3 of the male population and half of the female population have sexual problems. And when we are trying to talk about antipsychotics, antidepressants, this particular figure becomes just double. So sexual problems and our psychiatric practice has a strong correlation, and one should almost always keep it in mind. We did an epidemiological study of sexual disorders in South Indian population. What was actually found was that almost about 21.15% of the male subjects, of which in fact 15.77 had erectile dysfunction. This is one of the studies available in the general population from the Indian context. Also, sexual disorders among elderly and epidemiological study in the Suttur rural population. In fact, the point what it actually brought out was that only 27.4% of the individuals above 60 years were sexually active. And somebody 75 years of age and after, they were not indulging in any sexual activity at all. This was actually maybe from rural point of view, but all said and done, only indicates that people believe that at that particular level, at that particular age, sex is actually something anathema and we should not actually indulge. So much out of what we basically call myths and misconceptions actually gather. This is only a small 1 or 2 points here necessary, what we have mentioned about men and women. One should almost always keep in mind hypoactive sexual desire disorder. And this, if it is actually established, leading to erectile dysfunction, and this may vitiate the number of people presenting with problem, actually how they can. Arousal disorders and orgasmic disorders have been commonly reported in a lot of epidemiological studies. And what we basically call, when we are trying to talk about treatment and related issues, the important point what we should remember is actually the etiological factors, that it is extremely common. And one important parameter in the beginning itself to assess their motivation and psychological sophistication for treatment. One important point is actually when we are focusing on what we basically call pharmacotherapy, low inadequate intelligence or whatever sophistication, pharmacotherapy actually acts as one of the important line. And what we basically call those people who are actually having what we basically call highly educated psychological sophistication, non-pharmacological treatment and whole range of behavioral treatments can be tried. Failure, combination of pharmacological and non-pharmacological measures work out extremely well. Reported figures starting from anywhere between 70 to 100% improvement in quite a few people, depending upon patient population. The literature is available actually as far as individual, in fact, treatment is concerned. Coming to what we basically call erectile dysfunction, many of the times, whether individual alone is coming or whether it is actually couple. This is a general statement related to all sexual problems. What it means is, if an individual is comfortable with something, we need not have to do anything at all. But the desire for sex and frequency of sex expected between couples is actually at variance. That's where the problem actually comes into being. He is happy to perform sex once a month and she is not happy with that. Here the individual actually has to be looked into. Many of the times, individual, when he is having the problem, he may not actually take it very seriously as there is a possibility. And many of the times, in fact, we have not done very organized study in this. When couple man comes and says that I am having sexual problem after a married life of around 20, 30 years, do keep it in mind. It is actually the affairs and such other related factors actually might be actually the cause for actually he is seeking the help. So it is actually two people problem, and that's what actually one has to keep it in mind. Partner presented as normal. This I have presented in earlier presentations also, but what actually I'm trying to convey is, there was a fellow who came and told that he's having sexual problem and it is ED. Going back to the details, in fact, the fellow has married a distant cousin's daughter, and she is having what we can diagnose a sexual aversion disorder. She doesn't allow this particular man to come near. She will create holes, hue and cry. At the end of 4th year, he went and told mother-in-law that I can't wait any longer and I want to marry somebody. Mother-in-law told him next day you come, and he went to home. It's a big house, and in the hall they had kept the cart. This girl was running helter-skelter. Ultimately, they caught hold of her. brought to the cot, one lady holding one arm, another lady holding one arm, one lady holding leg, another holding another leg, and one lady pressing pelvis, and they told him, perform. He says he removed the pant, he couldn't get the erection, and the comment made was, you are not a man, why you are making fuss? So, history, and history, extremely important in establishing what actually we are trying to do. It is a two-person problem, immediate and causative effects, all of these things were actually kept in mind. Sexual difficulties, wherein actually, in fact, among these two couple, things are not going on smoothly for various reasons. I still remember one of the recent one and sometime back also, this Marwadi couple, he says, I can't stop chewing pan, but she says he chooses pan means let him choose pan, but I won't be with him. He is more than willing to forget her and not willing to overcome this particular difficulty. These are all sexual difficulties. We should establish in the beginning itself whether any such related things are happening. Relationship and such other issues are also extremely important in mind. And when we are trying to talk about management of ED, I mentioned that after sildenafil citrate, 2 years later, that major study that came about couples and it had not changed. What was actually documented was, as Levin mentions, that emotional satisfaction. We as psychiatrists were all well aware that many people come and tell us about sleep problem, but husband says she sleeps more than what I sleep and she is very nicely sleeping, but all said and done, she will be complaining about sleep problem. The same story goes with sexual problems also. That emotional satisfaction which actually missing is actually one of the major common problem for what actually happens to this particular individual. Where ED is classification and it is actually present. Of course, disease means a very specific cause. We don't know, and that's why, as in psychiatry, these are all described as disorders. And inadequacy and dysfunction. What it actually means is there's problem in sexual response cycle. We are all well aware what Marston Johnson's came out with the 4 stages to what we currently believe: desire, arousal, orgasm, and resolution. If any problem in any one of these type of phases, this is what actually they are discussed under. So ED comes under what we basically call as one of the sexual dysfunctions. And sexual response cycle is one of the important criterion. Again, they to go it unless you go into adequate detailed history. We are all well aware, men are almost like incandescent bulb when it comes to sex. They get aroused very fast and they lose erection and there is a refractory period. But woman takes her own sweet time. Many of the times ED, when we are trying to talk about, the man to get erection and ejaculation is extremely easy for him sometimes. But what happens is actually the partner is left high and dry. We are going to discuss about premature ejaculation sometime later. But all said and done, this discrepancy in what we call sexual response cycle between man and woman is one of the extremely important component what one has to. This is from one of the important books which talks about, of course, man gets aroused, ejaculation, and there is actually a refractory period. The woman takes her sweet time. Stri means istri means stri. Slowly it actually hits up, can reach orgasm, may not, multiple orgasms possible. You remove the plug, still it is very hard. And some people may not experience orgasm at all, but they can. But whole burden of actually getting erection and doing something falls on the man's head. And that's why actually that whole problems related to what we call the performance anxiety. Lack of loss of sexual desire, sexual aversion, and failure of genital response. That's where actually this ICD-10 talks about. But little more further improvements, sexual dysfunction, sexual pain disorders actually classified under what we basically call ICD-11. Sexual arousal dysfunctions is actually where these disorders are dealt with. DSM-4 was better than ICD-10 for simple reason that there was a differentiation between psychogenic and organic. Secondary to one or other factors was actually, it was very classically established. And we are all well aware there are very specific disorders which are actually discussed under this particular section. I'll try to just very briefly in about a minute speak about World Psychiatric Association diagnostic assessment which came out, a multi-axial system none of the international classifications available which talks about ED the way it should be discussed. Many of the times ED may be related to so many other factors which are actually nowhere related to either organic or anything, but all said and done for other psychosocial and other related factors. So it speaks about two components, one STD multi-axial formulation, other one is second component idiographic personalized formulation. Clinical disorders in axis 1 for which he has sought help, and what it mentions is other mental and general medical disorders should almost always be coded. This is a big improvement from the earlier one because actually what we were missing, why actually somebody doesn't respond adequately is actually based on this fact. Disabilities, contextual factors, quality of life, these are the three other things. So when you are trying to talk about disabilities, it might have affected personal, occupational, with partner, other relatives, social in general, none minimal to massive, one can actually score. And other contextual factors when we are trying to talk about family, house, education, economic, cultural, environmental, and personal. This education and economic and family house, there are a lot of cosmopolitan and metropolitan cities where there are about 10 people staying in one single tenement. No privacy and many other such related factors. Somehow, none of our international classification systems bring into the focus, and ED management cannot be done without looking into some of these type of things. And there is a scale, quality of life, a visual analog scale can be utilized here, starting from poor 1 to 10 excellent, gives actually an idea what actually it is. When we are trying to talk about ED, something happened sometime, one incidence of not getting erection, that sort of things should not be labeled as what we basically call ED. This problem should be present consistently in partner activity for at least 6 months. And this has led to significant stress. Partner, relationship, personal vulnerability, culture and religious factors, and other medical factors need to be looked into. There are a few more other important points. One has to establish in the beginning itself is whether it's a lifelong or acquired, generalized or situational, mild, moderate, and severe. How we go about, this is one another different area altogether, which take a lot of time. So when we are trying to talk about management of sexual dysfunctions, particularly ED, a proper history and examination, that means evaluation, is extremely important to establish, in fact, to help the individual to improve libido, acquire and maintain erection, and delay ejaculation. So these are the principles on which actually one has to, in fact, evaluate. So problem, organic or this thing in the history itself, we get certain points, younger, acute, situational, intermittent, decreased desire, absent or variable organic risks, partner problem at the onset, anxiety and fear actually established primarily. They all indicate predominantly psychogenic nature. Older the individual, gradual in onset, one or other organic risks present. In fact, these are the cases where possibly the organic factor has to be kept in mind. So when we are trying to talk about evaluation, I will not go into many details. Routine evaluation is absolute necessary. What we basically call maybe CBC, glucose parameters, kidney parameters, renal function, means renal function parameters, liver functions, lipid profile. These are the things very, very commonly one has to actually do and establish. There are some special tests. Again, I'll not go into too much because again, the treatment area we need to, the hormonal assay. See, there are two types of opinions available. There are some specialists who say hormone assay not necessary in majority of the individuals. If you are trying to working in a tertiary care center where you need to establish, this hypogonadism is an actual most important common factor you have to establish. It is very confusing. I myself used to get confused with so many things. I have spoken to endocrinologists and very specifically few important points what we realized is extremely important from ED management. That's what actually I'm going to tell in briefly. In primary hypogonadism, FSH and LH are both to normal and low testosterone. In secondary hypogonadism, normal to low, FSH and LH, and testosterone. So when we are trying to talk about hormones, Keep it always in mind, the thyroid function tests, FSH, LH, testosterone, both total and free. Free testosterone costly. Sometimes the SHBG level assessment means actually that give exactly idea. For all practical purposes, more than sufficient. And prolactin. These are the few things what actually one has to establish in the beginning itself. I'll not go into too many details related to, because antipsychotics primarily as a news, and we are not going to talk about those things. International Index of Erectile Function is one of the things which talks about different degrees of problem what individual can be having. 15 questions related to, in fact, the score of 1 to 10, 11 to 21, 20 to 25, 26, actually starting from mild to, in fact, severe, one can establish without much difficulty. People use that what we call, there are 5 questions which deal with erectile dysfunction. IIEF 5. In fact, again, the scores are available, which talks about whether we are dealing with a mild or very severe form of what we call as the erectile dysfunction. For the treatment of this, and even for the evaluation purposes, intracavernosal injection of vasoactive drug. One of the important things is actually papaverine, very commonly used drug, to, in fact, prostaglandin and phentolamine from the treatment point of view. So papaverine injection and Doppler and such other studies can give you exactly the idea to what extent this particular problem is, whether it is the mild or severe. From treatment point of view, single drug to bimix, trimix, and quadrimix, and a lot of other things well prepared already, which works out a little costly too. In fact, how actually this can be prepared at your local place, there are a lot of such details are available. There are plenty of validated questionnaires are available. I will not go into details, but this particular slide gives certain common questionnaires. We can use it for what we call as the evaluation purposes. Somebody who is interested in different scales and for research purposes, Sandeep Grover has published this assessment scales for sexual disorders in Journal of Psychosexual Health, available, and anybody requests, we can send this particular article without much difficulty. More than 28 plus different scales actually have been evaluated, in fact, regarding their usage in the clinics and in the research settings. There are a lot of other tests are there. Possibly if somebody calls an andrologist or urologist, they will tell about a range of tests what we do. Unless we are planning certain very specific things, all these tests are not necessary. Self-injection trial, ICVAD, somebody is planning a diagnostic, in fact, a prosthesis implant, venous ligation, neurological problems, vascularization. In fact, these are the cases which need very detailed evaluation related to, in fact, the vascular structure to lot many other things. But from psychiatrist's perspective, their role is actually very limited. What we psychiatrists can do is actually the assessment by, in fact, nocturnal benign tumescence. The clinically itself can give certain ideas. Stamp test and so many other such very simple tests can give some extent to the meaning to this, or the very specific RIGI scan, the recording for 3 nights very specifically and taking average related to this particular RIGI scan method, which can give us how many times, in fact, this type of response actually has been documented. So this is up to this particular level. I have spoken about understanding erectile dysfunction, causes of erectile dysfunction, and how actually one can go about understanding evaluation and related factors. Let us deal with what we actually call management of ED. When we are trying to talk about the treatment of erectile dysfunction, one of the first line is actually identify and treat curable causes of erectile dysfunction. Lifestyle changes and risk factor modification. There is another one, a whole different area. Very briefly to tell, exercise, diet, and lot many other things, lifestyle issues become extremely important for management. Provide education and counseling to patients and partners. So these form the primary line. Identify patients' need and expectations, shared decision-making, offer conjoined psychosocial medical treatment. See, if you try to open books maybe about a decade or maybe more, 2 decades or earlier, the first treatment line used to start with intracavernous injections, vacuum devices, intraureteral topical orthostadil, and many other such things. But now, almost all treatment guidelines, the first line therapy is actually PDE5 inhibitors. This should be tried adequately, and only then one should think in terms of something else. Many of those other treatment techniques could be actually, in fact, what we call invasive, and such other things are possible. So coming to first line therapy, to put it in another different way, oral therapies form the primary line of what we basically call actually the therapy or ED management. This is prescribed by both sexual medicine physicians and private practitioners, and for everybody, this is one of the very convenient. The confidence with which you write depends upon how frequently you have used it and how frequently you have looked into all the actually aspects which are. The second line therapy is urethral and topical orthostadyl, intracavernous injection, and vacuum pump. And the fourth one, in fact, the penile impact corrective vascular surgery. This is again, these are a few different guidelines which I have spoken. What I was trying to bring out to the focus is the primary line is actually the PDE5 inhibitors. Coming to PDE5 inhibitors, because it is already there, and there are quite a few people who are well versed with the whole aspects related to this. And we are all well aware it is nitric oxide mechanism, vasodilatation, erection, what it comes. But unfortunately, this phosphodiesterase E5 metabolizes, or because of which actually the erection is lost. So cyclic GMP, the PDE5 inhibitor, can prevent further changes, and this is why actually the erection comes. All the guidelines recommend PDE5 inhibitors as the first line therapy in the management of ED, irrespective of its cause. There are different guidelines I have just mentioned here for the purpose. There are a range of PDE5 inhibitors are available now. If I can tell for the young people who are listening to me, the sildenafil and tadalafil are the two extremely common drugs. Avanafil, udenafil, in fact, they are in vogue. In fact, one can use it, but they work out extremely costly. And when you are trying to talk about sildenafil and udenafil, we are all already well aware when actually it should be taken, at least about half an hour, 1 hour earlier. And one has to initiate activity to actually, for the drug to act. Tadalafil is having the very long half-life, and because of which, in fact, it is also called as where actually the availability of partner is in question and there is a confusion. This is the better. In fact, one of the reasons is called as a weekend PDE5 inhibitor or power drug, whatever you call it. One of the point what has been mentioned is about at least half an hour, 1 hour earlier, which may be actually like mouth dissolving. Certain other drugs which have been actually manufactured can work out a little faster. But as far as tadalafil is concerned, one of the consensuses available is that it should be taken at least about 2 to 4 or 5 hours earlier for getting the better effect. Flushing, headache, dyspepsia, which actually has been reported with sildenafil citrate, and certain other what we basically call genetic and such other diseases, keep it in mind. But for these things, these drugs are extremely safe drugs and one can use it without much difficulty. What are the recommendations? This is the first 5 recommendations have been adopted from the 3rd International Consensus on Sexual Medicine. And this is published in Journal of Sexual Medicine 2010. Phosphodiesterase type 5 inhibitors are effective, safe, and well-tolerated therapies for the treatment of men with ED. There are no significant differences in efficacy, safety, and tolerability among PDE5 inhibitors. PDE5 inhibitors are the first-line therapy for most men with ED who do not have specific contraindication to their use. Of course, there are other treatment techniques actually one can make use of. That's what actually it talks about. The important point is clinical considerations. What can be certain very specific ideas which can be gelled out of is all PDE5 inhibitors have an excellent efficacy and safety profile. No evidence that one PDE5 inhibitor is better than the another in efficacy or less adverse events. Patients using different PDE5 inhibitors have similar perception of improvement of treatment. Direct comparative studies are lacking and preference studies are inconclusive and biased. Give opportunity to try different PDE5 inhibitors, improves compliance and satisfaction. And one of the methods suggested is the a la carte method. Which one is comfortable about, that should be fine. Dose titration for a given PDE5 inhibitors to the maximum tolerated dose. Say take an example, if sildenafil citrate somebody is talking about, it is 200 milligrams. If somebody is talking about tadalafil, 40 milligrams. So it's strongly recommended because it increases efficacy and satisfaction from treatment. Despite the favorable clinical data, there is a high dropout rates exist both in East and Western studies. Up to 50% of the patients stop treatment owing to the issues such as cost, inadequate efficacy, and adverse event. More than anything else, I should have it naturally. I don't want to continue. These are the few of the very commonly reported, in fact, ideas. Clinical question. How to select the best PDE5 inhibitor in a given individual and address the dropout issue. One can talk about this in a very big way. So it all depends upon for what we are going to use. Sildenafil is supposed to give the better hardness. Tadalafil has a very long half-life. So there are, each drug has some particular ideas. So proper pharmacokinetic and pharmacodynamic issues being aware of is actually one of the extremely important. We published a prolonged, long-standing ultra-high dose abuse of sildenafil citrate. This individual was varying between 1,200 to 1,300 milligrams per day for 2 years without break. And when we evaluated him in great detail, hardly anything abnormal we could find. There are data available actually around 700 plus milligrams of accidental consumption of sildenafil citrate. Nothing really major has actually happened. All said and done, there are some non-responders to PDE5 inhibitors. Who are they? Almost 25% of the patients may not respond to PDE5 inhibitors. Currently recommended 8 doses of PDE5 inhibitor with sexual stimulation at maximum dose before classifying a patient as non-responder. Improper use of PDE5 inhibitor is the main reason why the patients fail to respond. One of the things actually what I very fond of telling, somebody takes PDE5 inhibitor, say sildenafil citrate tablet and sleeps, maximum hair on his head will stand up. For getting erection, in fact, foreplay, stimulation, self, or by partner, fantasy, all these type of things are extremely important. Failure to use adequate sexual stimulation, adequate dose, adequate amount of time between taking medication and attempting sexual intercourse has been found to be one of the major common cause for what we basically call the drug failure.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
What it means is having a proper idea is actually one of the extremely important step. You have to spend some time to explain to the patient how actually things would go. Non-responders to PDE5 inhibitors, we are well aware, recounseling, treatment of concurrent diseases, concurrent hypogonadism if it is present, regular frequent dosing regimens, some of these type of things actually may bring about remarkable changes. There are a few contraindications. So one actually has to keep it in mind, the heart disease and related things, the BP and such other things, following MI, congestive cardiac failure, concurrent use of what we call as nitrates and nitrate donors. Few of these type of things actually one has to keep it in mind. Patients who have suffered from a myocardial infarction, stroke or life-threatening arrhythmia within the last 6 months. Patients with resting hypertension of less than 90 or 50 and or hypertension of more than 170 or 100. Patients with unstable angina with sexual intercourse, congestive cardiac failure categorized as New York Heart Association class 2 or greater. Patients taking any form of organic nitrate or nitric oxide. These are the few things. And more frequent regimen helps. There is a data available. And concurrent use of certain drugs which actually inhibit or can create difficulty, one should almost always keep it in mind. And we as psychiatrists will be writing plenty of drugs. Majority of the drugs what we are using can create difficulty. And from that particular angle, vortioxetine and agomelatine, there is no reported sexual problem. bupropion, mirtazapam, agomelatine, vilazodone. In fact, these are the few things which have been actually found to be quite useful. That means those which drugs acts on 5-HT1A receptors are actually beneficial. PDE5 inhibitors can be combined with what we call which centrally acting drug, like apomorphine. How one should use it, we'll try to talk about it if later some questions come. So almost always keep it in mind, this hypogonadism or in fact hypoactive sexual desire. One or other organic factor responsible, please try to correct it. Correct it by, in fact, androgens. In fact, when you are using the word androgens, one has to be very careful. Androgen is a lifelong therapy. Giving it only for a short while, it is not going to work in that particular fashion at all. So one has to make a very significant proper evaluation to see that where actually the things are. Recent evidence, only minimal beneficial effects on sexual function. Unless hypogonadism is there, androgens are not going to work. Testosterone increased sexual arousal and enjoyment in hypogonadal and normal men. Positive effect on mood among men with abnormally low testosterone levels. Males with normal testosterone levels not been shown to facilitate erection. So these are carry home messages one has to actually keep it in mind. Androgens are necessary for a whole lot of purposes, both in case of men and women. And when we are trying to talk about a desire component, this is one of the extremely important drug. What is actually advised is adjust slightly above lower limit of normal. Beyond this, negligible change. How much testosterone should be used? Anyway, this particular slide is available. One of the most convenient thing what I have found is actually like depot injections like Sarnos injection, testosterone undecanate 1000 milligram for 4 ml once in 3 months. This is one of the easy methods actually to work out. And there are a whole range of other drugs, injections are available, say Sustanon and something like that. Though specifically I am mentioning this name not because of anything, it is the combination of esters, whether weekly or once in 2 weeks or once a month, depending upon the dose adjustment one actually. I told testosterone, when we are actually considering, one has to be very careful. One of the advice by endocrinologists is that FSH between 2 to 5 milli international units. In fact, clomipene citrate works wonders. Testosterone decreased, FSH is more than 7 milli international units. Check estrogen, and certain drugs need to be given for that. If testosterone is low, less than 200 nanogram per deciliter, HCG is one of the actually best drug. And when we are using testosterone as such, keeping in mind coronary artery disease, risk of malignancy, to enlarged prostate, to lot many other things, what one has to keep it in mind. Many of these type of things are overcome by some of these alternatives for what we basically call the difficulties involved. So there is sexual discrepancies in sexual desire. So psychotherapeutic things, such other techniques to bring about. So desire, if problem is present, individual is likely to have VD as actually subsequently to this thing. There are a whole range of drugs available to correct, apart from this, from hormonal point of view, dihydrotestosterone, most abundant androgen, associated with sex drive, especially in women. It is association with exercise. What actually is being said is that if a man can perform about 20 to 30 minutes of exercise regularly, the testosterone, in fact, dihydroepiandrosterone level increases by about 2 to 3 times at the end of 3rd to 4th week. What it means is the lifestyle changes itself can bring about quite a bit of changes. One of the other thing is actually it can be used in the form of drug, and people have documented certain beneficial effects. The whole range of drugs are available. If somebody is not responding to one, anyone can be chosen from any one of these groups. Those which act at the central level with the initiators, peripheral acting with the initiator, central with the conditioner. What are they actually? In fact, central initiation, apomorphine, conditioner, testosterone, prostaglandin, papaverine, and such other drugs. And what we basically call at the cavernous level, peripheral conditioner like sildenafil citrate. And there are a lot of questions that may come up later, whether PDE5 inhibitor, only one or combination of these drugs, whether it should be used or only on the basis of necessity one can use it. Whole lot of things. If nothing works, of course, processes and such other related things too. In fact, before that, what we call vacuum pump. So the range of treatment techniques are available for the management. Medication-induced sexual dysfunction, and which is leading to what we basically call choose a drug. For example, we as psychiatrists try to choose any drug, whatever drug, and that is not the thing which is actually going to work properly. Determine sexual functioning before treatment. Attend to medical and psychological interpersonal issues. And some of the drugs which actually having the least sexual problems among antidepressants and antipsychotics, I have just mentioned it there. Some people have suggested briefly stopping offending drug, switching drugs, reversal with amantadine, dextroamphetamine, cyproheptadine, pramipexole, and use of what we basically call sildenafil citrate or other PDE5 inhibitors. If people are having, in fact, certain difficulty related to delayed ejaculation or orgasm, certain drugs can be used, starting from bethnecol, cyproheptadine, amantadine, bupropion, which I was mentioning. We are all well aware and comfortable about many of these drugs in our clinical practice. DAS syndrome, many people have many myths and misconceptions. Correcting this, including what called the anxiety related to certain drugs, is extremely important. That should be done. So management of male sexual disorders in general, lifestyle changes, weight loss, physical activity, these are all extremely important. Psychotherapy, there is no shortcut for that. When we are trying to talk about pharmacotherapy, PDE5 inhibitors form the main line, testosterone, yohimbine, and few of the other things. Penile injection using whole lot of pharmacological agents, alpha-steroid to papaverine, vacuum-assisted erections, and where necessary, surgery and penile process and penile vascularization. So these are all few of the things which are actually well established, clearly talking about whole range of therapies available for what we basically call management. And pharmacotherapy forms the main line. In what we basically call, men believe sex means actually it is screwing. The terminology must have come. It is a nut and bolt phenomenon. In case of man, treatment is easy because all erectogenic tissues are situated at one particular place. Pro-sexual herbs people have come out with. I am not going to elaborate on that, except that, in fact, the important message what it actually conveys is they improve mood in general, and unfortunately, very specific what we basically call how actually it can be used, what is the extent, the robust research findings are actually missing. One of the idea what actually one has to keep it in mind is actually this Anand's model of permission giving, limited information, specific suggestions for many. Pharmacotherapy works as one of the important step in that, and intensive therapy only for a small number of people, it may be actually necessary. And what I have actually so don't neglect. In fact, one of the important point is ignorance, we correct it by education, cultural taboos by permission giving, poor communication skills, teaching communication skills, sexual failure leading to the vicious circle of fear of failure, and if there is a particular precipitating factor present, removing it, and removing their actually called performance anxiety, such as the related things, and in some individuals, intensive therapy. Important issue is establish pre-morbid sexual functioning, primary psychiatric disorder and drugs treatment for that, comorbid physical illness and medication, what actually he may be taking, and psychotropic medication. Many people have myths and misconceptions. Correcting it actually extremely important. So one of the important message of my presentation here is dysfunction cannot be treated in isolation. Individuals seen in the context of relationship. Biopsychosocial model works. Helping couple function optimally should be our aim. Basic information on anatomy, physiology, eliminating myths and false expectation, extremely important. Removing performance anxiety and individualizing the treatment is actually what actually people suggest. Optimization of treatment, adequate attempts, proper dose titration, partner sexual dysfunction, all extremely important to be kept in mind. Sex education, modification of risk factors, and in fact, now the whole range of therapies are available, what you call as combination therapies, gene therapy, surgery, processes, etc. This whole world is actually there in front of us. Thank you so much for allowing me to present my ideas. And any questions, we'll be more than happy to actually share.
Thank you, sir. Thank you so much. Over to chairpersons for their opening remarks.
First of all, I'm very thankful to all of you, especially the organizers, and also the great participant. And especially I'm thankful to Dr. T.S.S. Rao, who has command on the subject, and he's very popular not only in India, but all this region is in Pakistan as well. So I think he covered most of the areas, starting from the causes and the various therapeutic approach and diagnostic approach. I think this is a huge knowledge which he has very interestingly covered all aspects. Although this is a subject which really wanted a lot of weeks to understand, and also, and one thing I have in mind that most of the stuff was related to male sexual problems. I think one of the participant has asked in the chat box that what is the specific drug which can be used in the inadequate response in females, and also if there is high desire among the females, so what could be the strategy in that case? I think this was a relevant question, and I'm very grateful to all of you for giving me this opportunity to learn from a very renowned person who has command on the subject of psychosexual behavior, Professor Rao. And I'm also thankful to Dr. Aleem Siddiqui for very good organizing this program. Thank you very much to all of you.
Dr. Amit.
Thank you, sir. Thank you, sir. Myself, Amrit, Vishal are the moderators. So, and Tufan, sir. So all of us do it together as a team.
Dr. Amit, I would request you to, maybe he can't unmute. Let me try and unmute.
Dr. Amit, you're muted.
Please unmute Dr. Amit. Vishal, please unmute Dr. Amit.
Yeah, I'm Dr. Amit, I have sent you a message to unmute. Please unmute yourself.
Yeah, I have unmuted. It was an extensive as well as comprehensive topic by Dr. Professor Rao, sir, and extremely lucid way he has covered the various aspects as far as the erectile dysfunction is concerned. One thing which I would like to share to the audiences here, that the PDE5 inhibitors are also known to cause tachyphylaxis, means over a period of time, there is a failure to respond to the same dose of PDE5 inhibitors. So I would always prefer or recommend the beginning dose to be the lowest possible dose. So for example, in case of tadalafil, it would be 5 milligram. And in case of sildenafil, it would be 25 milligram. Of course, the patient's weight and other pathological disorders are also important determinant of the dose, adequate dose for the patient. So thank you, sir, for giving me this opportunity to be a chairperson of this particular session. As always, for the last 10-12 years, it was a great learning experience. Every time I hear Dr. Rao, I get to know some new things about the same topic. So that is the crux of education, that you learn each and every outing. Thank you.
Raj Brahmabhat is there. You can ask him to make some comments.
Thank you.
He is my mentor.
Pardon, sir?
Dr. Raj Brahmabhat is there.
Please unmute Raj Brahma. TSS, sir, can you make me host? Because I internet conged of me. If you can transfer the host rights to me. Vishal, please unmute Dr. Brahmbhatt.
I'll do that. I'll do that.
Rao sir, please make me host or co-host.
We,
Sir, please unmute yourself. Brahmbhatt sir, I have asked you to unmute, sir.
Now it is unmute. Can you hear
Yes.
me?
Yes, sir. Yes, sir.
Yes, sir.
I have been seeing Dr. Rao for last 30 years, you know, and amazing work. Every time he goes one step further. And the way in which he has conducted the whole talk, you know, he started with a very beautiful way at the beginning. And I think it's a treat to listen to him about complete things he has given within 1 hour and I think 15 minutes. Complete erectile dysfunction. And he has got the pulse from all around and beautiful slides. Dr. Rao, my heartily congratulations. Amazing slides. The slide, each picture speaks 1,000 words for itself. And Dr. Mutta, very nice to see you also as a chairperson, and you give a very nice comment too. Keep it up. I'm proud of both of you. And you people are rocking. Great. Great. Keep it up.
Thank you.
Thank you, sir.
Thank you.
Thank you
sir.
so much. Rao sir, if you can
Yes, sir.
make me host.
I have to make host, is I?
Or co-host.
Yes, sir. Sir,
Because
you go
the host
to
has transferred to you.
So you go to security settings, and I think you can do that.
No, you just click on my name on my
Acha.
photo.
Okay.
Right. Three dots.
Just click on the participant's name and make host.
Photo by
Sir, I have one observation or comment to make.
Congratulations. Alim ban gaya.
There was this
Thank you.
Dr. Gentleman who said that women have very high desire or something similar. I want to make one comment here. Everybody's appetite is different and it is not high or low. It might come across as high because they are not satisfied. If they are adequately satisfied, I don't think there is something called as high desire in women. More or less, male and female both are having equal desire, less desire or more desire, because everybody's appetite is different, everybody's diet is different. So we might have different preferences and different cravings. So that is what I would like to tell the gentleman.
Alim, if there are questions, we'll try to answer some of those things also.
Sir, first of all, regarding this sort of tolerance issue with PDE5 inhibitors, so if you have to use long term,
it is basically
how to use it in
tachyphylaxis. It is basically tachyphylaxis.
Now, the point is,
yes,
I have not come across anywhere significant tolerance developed for PDE5 inhibitors. What Dr. Mutta is suggesting is, don't start with what is called extreme, the maximum dose which can...
Tachyphylaxis.
Start with the small dose. Depending upon the tolerance and what is the convenient dosage, you go up to that particular level. Many of the people, so for example, elderly start with 25 mg, and young individuals, in fact, 50 milligrams can be very comfortably used. And depending upon what PDE5 inhibitors you are trying to use, it all depends on various other parameters, as I was trying to suggest that. There is no significant tolerance being documented.
Okay, so suppose we are talking about tadalafil and sildenafil. So what is the upper dose ranges that you have tried for long term, for longish period?
See, as I was trying to tell you, the upper limit literature speaks about, research studies talk about 200 milligrams for sildenafil citrate. We have gone up to 300 milligrams also in occasional individual. And along with certain other procedures also what we have actually gone. Tadalafil, about 40 milligrams we have used. If somebody is not responding for certain length of time, say as we were trying to talk about, say about 8 weeks or so, take an example, then there is no meaning in continuing that particular thing. Try to remove what all the misconceptions maybe he may be having or how he is using it and a whole lot of other related other comorbidities which may be present. This is actually one of the lines. There are actually people who suggest, say for example, tadalafil 5 milligram, what Dr. Mutta was mentioning, regularly using tadalafil 5 milligrams and where necessary to increase it to 20 and the other related that particular way, where necessary. So that means you are building it up in a consistent fashion and This is supposed to give beneficial effect in certain individuals. People have spoken in that particular.
So for daily tadalafil, suppose lower doses, 5 mg we're talking about, 2.5.
Yes.
So how long we can continue daily?
It can be continued for any length of time. As it stands, there is no literature available which says that it should not be continued beyond this particular point. My guesswork is, in fact, we have only around 10 or 12, 15 years of experience with these molecules. So as it stands now, these drugs are quite effective and should be continued.
Okay. Sir, regarding apomorphine, how to use it? What is the suitable candidate for this, and precautions and things around that?
See, at one particular time, before sildenafil citrate was available, this was one of the drugs which was considered as quite effective one. At one particular time, it was one of the very popular drug also. One important point, apomorphine, in fact, vomiting and so many other related risks which are associated with that. What people have documented is about 2 milligrams or 3 milligrams and up to 6 milligrams one can go sublingually. In fact, this should be used. That way it can bypass what you call as liver metabolism, and it acts at the central level. What actually has been documented along with tadalafil, if it is not responding, apomorphine and tadalafil, apomorphine and sildenafil citrate can be combined, because see, sildenafil citrate and other PDE5 inhibitors, they act only at the cavernous level. Apomorphine acts at the central level. So beneficial effect can be given. That's why actually I was showing one of the diagrams with about 4 cubicles, where any one of the drugs in any one of these combinations, people have tried and have found actually beneficial in some individuals. And there is no contraindication for that.
Okay. I think we can take a few questions from the chat box. There is a comment on yohimbine. People want to know how effective and how to use it.
See, in my practice, very limited use I have done, but there are people who propound yohimbine as one of the very important drugs. In fact, ultimately, the effect is 5-HT1A receptors and alpha-adrenergic property. 50 milligrams to 100 milligrams, people have found the regular usage can give a very definitive beneficial effect. Yohimbine irritates, in fact, urethra and other related effects actually people have documented. So it is not beneficial for everybody. Somebody is tolerating and getting benefit, definitely this can be tried.
Okay. Vishal, do you want to take question from the chat box?
Can I ask one question from?
Yes, sir, please.
Yes, now if you look at the ICD-10 and ICD-11, there is a lot of changes. In ICD-10, F52 was specified for sexual dysfunction, but now the ICD-11 has just removed sexual dysfunction, all sexual dysfunction from chapter 6 of ICD-11, and they have given it the another chapter H. I think it is more, it will not serve the purpose, because sexual dysfunction is something to do with mental health and psychiatry. So what is your opinion? And as a leader of the Asian psychosexual problems, so we can write to the ICD-10 that they should, what was the justification or rationalization for this?
Okay. See, at one particular point, we all believed sex is there in the mind, and that is the way actually all of these things were dealt in chapter 5 in the initial part, the sexual problems. But the point is, when we saw psychiatry journals and psychologists coming out with almost about 80-90% of the problems, it is psychogenic. At the same time, reports started coming from diabetes clinic, urology clinic, and a lot many other this thing, which was speaking about almost 70-80-90% of the problems are actually having organic basis. So there was a whole lot of conflict and issues involved. And there were objections because it is a psychiatric disorder, means some stigma and other related points were actually brought forward. The third point is, this is if it stand alone, everyone can contribute and they can claim right on this particular thing. Say, for example, a diabetologist can work on, rather than working on psychiatric disorder, he would like to prefer to work on sexual problems. No, no, there is a very subtle difference, but this is the way argument went on for a long time. And we had corresponded with actually that taking out is from the psychiatry section is actually a disservice done. But this is all the explanations that were provided to say that this particular branch need to develop independently, individually in a big way. This is the idea.
Okay, thank you very much.
Sir, there are a couple of questions in the chat box. If you permission, I can read them.
Please, sir.
Sir, one is that this combination which happens a lot in the market, depoxetine and tadalafil combination, sir. How do you look at it? One question on that.
Okay, I think my guesswork is I don't mind staying for another about 10-15 minutes extra to see that all the questions are answered. It all depends on the organizers. See, the point is, when we are trying to talk about premature ejaculation and erectile dysfunction together,
yes, sir.
that's where this depoxetine role comes into the picture. Otherwise, if it is an ED alone, better not to combine it with any of these type of combinations. That is one aspect. Second one, I have seen some of my postgraduates coming and presenting a case that this particular person is having diabetes, uncontrolled, he's having erectile dysfunction, then premature ejaculation. But you look at this fellow is having sex once a month or once in 3 months, and early ejaculation is expected. This should not be labeled as premature ejaculation. Somebody is having diabetes, somebody is having other systemic or metabolic problem. Better to use only purely specific PDE5 inhibitor. This is the idea. If there is a what we basically call say premature ejaculation is present for all practical purposes. Premature ejaculation, the only organic factor is actually basically he is a little fast on the gun. Everything is in fact anxiety related. So a drug which acts on anxiety all through would be a better one. All our antidepressants are much better drugs than very specific acting what call depoxetine on demand at some particular time. So this is one of the message I just want to convey.
Right.
Sir, if question from Dr. Bodani, if someone is watching excess pornography, will it lead to ED?
See, the point is, every man has some particular capacity to get aroused and actually perform. Take an example, when we are trying to talk about maybe a 20-year-old individual is different from 35, maybe 50, and maybe 70. Often pornography, what happens is actually he is finding the release and then actually he wants to perform with a partner. It is not going to work easily. So there is actually something called as refractory period, which can last from a few minutes, maybe 1 or 2 hours in a very young individual too. For the later individual, it may be 24 hours, 48 hours, 72 hours. So very likely it will fail. The second point, pornography is an easy outlet. There is no anxiety, no tension, nothing need to be managed. With a partner, there are a lot of things actually he has to deal and he may find it very difficult. That's why those people who very frequently watch pornography and predominantly, primarily addicted to it to a great extent, inverted comma, they have a lot of actually called sexual performance issues.
Okay. So another question is, which potency test is best, most trustworthy, easy to do? Potency.
See, as far as the potency test is concerned, ICVAT technique with what we call pepaverin or phentolamine or what we basically call prostaglandin. So bimix, trimix, these are all quadrimix. These are all few of the things what actually people have done. One can get a score, but see, this is one both for the evaluation and for the management. If you are trying to use this technique to establish potency, see, for example, nocturnal penile tumescence is present. That establishes potency. The history and other findings actually will establish certain things. The third point, from the legal and such other point of view, why we are trying to establish this ICVAT technique wherein you inject pepaverin. See, pepaverin injection available as 30 milligram per ml. Say each ampoule contains about 2 ml. Injection into this particular cavernosal bundles in that 11 o'clock or 2 o'clock position. In fact, it can bring about erection because a little bit of masturbation, or along with that, what we call video assisted, what we call as erotic stimuli. one can read and make an assessment related to how stiff and how fast and how long it actually came about. So these are the few things what people can do.
Sir, do you recommend any foods? There's a new concept of nutritional psychiatry. Do you recommend any foods or any diet for sexual?
Food served by a beautiful lady is almost always has stimulating effect. So that is an important point. Food served by a woman or somebody with good words or which improves confidence and whole lot of things. In fact, many of the times eating becomes one of the major issue, mainly because many of the times quarrel and lot many other things, conflicts come into the picture there, which creates difficulty. So any food and every food is actually found to be useful. When we are using the word aphrodisiac, there are certain specific what we call psychosocial aspects added to that, which makes something excellent.
Right, sir. So there are a
Any
couple of
comments
questions
on
of
ashwagandha?
It's Parammal, ashwagandha,
On ashwagandha, L-arginine.
See, Parammal, when we are trying to talk about many of these Parammal prelox, these are some of the drugs which have been actually strongly recommended. It is actually the arginine. Only 1 or 2 words about arginine. See, when you look at some of the preparations which contain arginine, it contains about 2 milligrams, 3 milligrams, 4 milligrams, 6 milligrams. What actually the research has documented is minimum 6 to 15 milligrams arginine is necessary for bringing about changes. We have reviewed the role of arginine in very great detail in Journal of Psychosexual Health. You just go there to the homepage and just click arginine. That particular article is available. There are plenty of phytochemicals available which contain arginine. But see that it is present in adequate dosage. These are not as effective as PDE5 inhibitors, but has added advantages as what we call as supplementary therapies.
So, there are multiple questions by a single person. Role of 5-HT1A antagonist, role of prolactin, role of reduction of dopamine in nucleus accumbens, role of cabergoline, role of testosterone, and role of phylbaserin in females.
Okay, just to put it in one simple word, see, for example, when you are talking about serotonin internally body-wise, it acts like a schizophrenic. You remove depression, his sexual performance improves. You have used certain antidepressants which can actually create problem. So one of the advice in the beginning itself is to choose an antidepressant which is having less likely problem actually effect. So any one of those drugs which act on dopamine mechanism, or say mirtazapam, around 20-30% risk, but it acts on multiple sites. So these are all actually found to be useful. Any drug which acts on dopamine mechanism or what we call as dopamine agonist that particular way has beneficial effect. This is one of the reasons why, for example, certain antidepressants which act on dopamine mechanism.
Bupropion.
Bupropion, so many other drugs. In fact, any drug which acts on dopamine mechanism has beneficial effect. It is an executive neurotransmitter and has its own advantages related to that. Try to see that anything which blocks this dopamine is not there. Antipsychotics. Try to see what best can be done. Coming to the specific drugs, go for vortioxetine, agomelatine. In fact, many people, they say it is very mild acting, but we have tried clinically in certain individuals. It has beneficial effect, how much you give actually. 25 milligrams or 50 milligrams in some individuals. Vilazodone, any one of our old classical drugs, what we are trying to talk.
Trazodone also?
See, trazodone, how actually it works and whether consistently it has been found to be in all individuals, there is a whole lot of question marks related to that. Nowadays, we don't use trazodone. In fact, that was at one particular time, it was actually recommended that way. But now we don't strongly recommend that.
Dopamine agonist, like some people use pramipexole.
Yes, it's pramipexole. Or you, any one of, for example, all anti-Parkinsonian drugs which act on dopamine. See, remove those drugs which act on cholinergic mechanism. Any drug which acts on dopamine mechanism has beneficial effect. This is one of the reasons why in treatment of Parkinsonism, suddenly the increase in desire and
libido,
and one has to be aware of that.
Right. Thank you, sir. Alim bhai, any other question on your side? One Dr. Usman
Sir,
has asked.
if you do penile Doppler study, what are the things to look for in the result of penile Doppler?
See, penile Doppler, when we are trying to talk about, one can actually make assessment related to the degree of erection individual can get. In fact, the parameters mild, moderate, severe, and profound disturbances one can document with this ICVAD technique. So this is actually a Doppler assessment. What are the changes which are actually producing? And the radiologist, in fact, the score related to what we call erection, what degree it is. 1, 2, 3, 4. In fact, they'll give, and that is one of the good assessment. One is penile tumescence, what we are clinically talking about. The second one is IIEF can provide that scale some extent. This Doppler associated study alone some extent. Doppler with ICVAD, that means with papaverine. In fact, it can give a much better clear-cut idea related to how much time it took for the erection to come and things like that. Even also the radiologist can document the anxiety and such other related factors which actually may be present. Only thing we have to be a little careful about priapism and such issues. So after doing that, make the individual wait for about 3 to 4 hours till the tumescence is lost completely. Don't send him off immediately after doing that Doppler study and send him.
Okay. I think Amrit.
Yeah, we can close it.
Maybe.
Yeah. It's late now.
I think we need to call Rao sir again because some questions are still there. PME we have still not covered.
Yes.
So Rao sir, we'll call you if you agree.
Absolutely fine. In fact, a lot of pending questions from last 3 sessions are actually there.
So just one question, one interesting question. Does anybody get addicted to tadalafil or sildenafil? Is there a risk of people especially?
Not so far. And you might have noticed the clinical consideration related to PDFA inhibitors I was mentioning there.
Yes, sir. You were doing. Yeah.
More than 50% of the individuals who have responded well to PDFA inhibitors will never continue. We thought this is our study, our clinical practice. Even in the West, everybody believes that they should get natural erection, and one of the most common thing what they have observed is actually people discontinue.
Right. So that will answer Dr. Usman's question also. Got it. Thank you, sir. Thank you. So we can close it.
Thank you. Yes. Amrit, over to you, please.
First of all, as always, T.S. Rao sir ka blockbuster रहता है. Even if there is a India-Afghanistan World Cup match going on, the more people are here. So
there is
more than 300 logins.
Yeah,
there's more than 300 logins.
Yes.
He covered everything patiently from the fundamentals. And the best part about him was he was emphasizing on the common things. He was not talking of uncommon things. If you look at the presentation, the drugs which we used, even though it seems too complicated, but he was always telling us to use the common things which work. And he was not emphasizing on very, very novel things or somewhere. That's the beauty of the presentation. So somewhere we all can be practitioner of what sir professors. You need to ask only one question. I know many times people used to, when I was in CIP, I would ask this question and these people would always tease me that why do people with sexual problems always come to even though they are my patients? So I think the ability to ask those questions in a non-judgmental manner, and not to give
I was examiner for Amrit, and very specifically we had asked him questions related to the sexual life.
Yes, sir. Mine too. Both of us were passed by you.
And one of the most important things is not making faces when people talk of problems is one of the major issues I have seen with a lot of sometimes they smirk, they smile. Those small things matter too much when somebody is talking about their most intimate and personal things, because 99% of times I see them taking out their partners. They tell their wives, please wait outside. The wives will tell, sir, हम थोड़ा बाहर wait करें, अकेले में आपसे बात करना चाहते हैं. Then you understand that yes, this man or this woman wants to talk alone, and that's very important. Thank you. We had Dr. Muhammad Iqbal Afridi all the way from Pakistan, and that makes us truly international. The problem is international, the solutions are international, and naturally I'm somebody who is very much interested in all these things, but Alim has problems in these areas, so he was very, very inquisitive to ask what works, how it works. So I allowed him to ask whatever he wants to. अब मेरा कोई कहीं काम का नहीं है सब चीजें. And Dr. Amit Mutha, all the way from Mumbai, thank you, sir, for joining us and helping us. And so we had a great session, and I think we will. And the best part about TSS, sir, is we had a last minute. Somebody was not well, so the last minute he agreed. That's the beauty of a great man. We have seen hundreds of people who will tell, please give us 1 month time. We are doing this, we are doing that. TSS are always there. He's traveling, he's doing anything. And I think that's something which we all need to learn and imbibe in us. So thank you so much again. We'll again meet TSS sir with all the questions, all the answers. It was great having you, sir. As
We can
always.
have one session on premature ejaculation. From psychiatrist perspective, that is one of the very, very commonly encountered area. I am sure after this
Yes, among our patients as well as among the psychiatrists, sir. So we should have it, sir.
Also,
thank you,
another
Dr.
separate.
Amrit, Dr. Vishal, and Dr. Pati, and especially Dr. Rao and Alim Siddiqui for such a wonderful session. I think people enjoyed, not only learned, but enjoyed as well.
Thank you so much, sir. Good night.
Thank you.
Thank you.
Thank
Catch
you.
you next time.
Thank you, sir.
Thank
Thank
you.
you. Good night. Thank you, sir.
Tofan
Thank you, Rao
Pati
sir,
sir is also
Afizi
saying.
sir, Amit.
Tofan Pati sir is also saying
Tofan Pati sir
good
is
night
there?
to everyone. Yes, sir, he just joined. He just said hello to everyone. So I joined earlier.
No, no,
Thank you, sir.
it's okay. I have heard everything.
Thank you, sir.
Hello, everybody. It's a nice meeting.
Thank you, sir.
It means there
Thank you,
is
sir.
an
Thank you.
internet problem. But I am here.
Hello, sir.
All the best, everybody.
Thank you.
Good night.
Thank you. Good night, sir. Okay. Please close the meeting.